At the gastroenterology clinic, there's a 63-year-old Caucasian male named Neil, who's complaining about progressive fatigue and weight loss in the last 6 months. Laboratory findings reveal positive fecal occult blood test and iron deficiency anemia. At the same time, an 18-year-old Caucasian male named Brendan came in for a colonoscopy screening. He was concerned after learning that both his grandfather and uncle were diagnosed with colon cancer in their early 30s. His doctor detected more than 100 polyps on colonoscopy. Now, both people have some form of colorectal polyps or cancer. But first, let's start with colorectal polyps, which are overgrowths of epithelial cells in the colon or rectum. They're subdivided into non-neoplastic polyps, like hamartomatous polyps, hyperplastic polyps, inflammatory pseudopolyps, mucosal and submucosal polyps, as well as neoplastic polyps, which include adenomatous and serrated polyps. Hamartomatous polyps are solitary, disorganized masses that contain normal tissue found at the site of the polyp. These polyps can occur sporadically, or in genetically inherited conditions, like in juvenile polyposis syndrome or Peutz-Jeghers syndrome, and they have mild malignant potential. Next, hyperplastic polyps are the most common polyps, and they're small and typically located in the rectosigmoid region. Usually these polyps are benign lesions, but in rare cases they can evolve into serrated polyps, which have malignant potential. Inflammatory pseudopolyps are multiple benign pseudopolyps that occur during regenerative and healing phases in chronic inflammation, and they're most commonly seen in inflammatory bowel disease. Mucosal polyps, which are clinically insignificant, are usually small, less than 5 millimeters, and they look similar to surrounding normal mucosa. On the flip side, submucosal polyps can include lipomas, leiomyomas, fibromas, and other lesions. Now let's switch focus to neoplastic polyps. Adenomatous polyps are caused by a mutation in the tumor suppressor gene called adenomatous polyposis coli, or APC for short, which is located on chromosome 5 and is responsible for the regulation of cell growth and cell adhesion. Moreover, the mutation of the APC gene is present in all familial polyposis syndromes, and most cases of sporadic colon cancer. Now let's focus on adenocarcinoma sequence, which includes 3 steps. The first step is the mutation of one allele of the APC gene, which leads to the formation of a small polyp, also called early adenoma. The second step happens when the small polyp acquires a mutation of the proto-oncogene called KRAS, which is further followed by an increase in the size of adenoma and formation of the late adenoma. Finally, the third step requires mutation of tumor suppressor genes P53 and DCC. Now, adenomatous polyps less than 1 centimeter are less likely to acquire these mutations and undergo malignant transformation, in contrast to adenomatous polyps greater than 4 centimeters, which are more likely to progress to adenocarcinoma. Furthermore, based on histological appearance, there are 3 types of adenomatous polyps: villus, which are cauliflower-like polyps that have the highest malignant potential; tubular, which are pedunculated polyps that protrude out into the lumen of the intestine and have the lowest malignant potential; and tubulovillus, which have characteristics of both tubular and villus polyps, and they have an intermediate malignant potential. Usually, adenomatous polyps are asymptomatic, but in some cases, villus polyps can cause bleeding, secretory diarrhea, and partial intestinal obstruction. Finally, serrated polyps are often flat or sessile, and are characterized by sawtooth appearance under the microscope. They contain methylated CpG islands in their genes. DNA methylation regulates gene expression, which can cause silencing of DNA repair genes, eventually leading to more mutations and malignancy. After polyps, let's look at colorectal cancer, which is the 3rd most common cancer worldwide. Most commonly, it affects people older than 50 years old, and in 25% of the cases, there's a positive family history. Risk factors for colorectal cancer include hereditary factors like familial adenomatous polyposis, adenomatous and serrated polyps, inflammatory bowel disease like ulcerative colitis, lifestyle factors like obesity, smoking, alcohol, and physical inactivity, and finally dietary factors, which include high consumption of processed red meat and low consumption of fruits and vegetables. Individuals with acromegaly, a condition where the pituitary gland produces too much growth hormone, are at higher risk of developing colorectal cancer. And finally, increased cyclooxygenase 2 activity is linked to some forms of colon adenocarcinoma. So frequent use of inhibitors of this enzyme, like aspirin, can lower risks. For your exam, you should remember that the most common form of colorectal cancer is adenocarcinoma, and it's most commonly found in the rectosigmoid, then ascending colon, and rarely in the descending colon. Initially, adenocarcinomas can be asymptomatic, but as they grow, their location determines their manifestations. Left-sided colon tumors are usually smaller, but as they infiltrate the wall of the colon, they encircle the lumen, eventually narrowing the lumen and causing obstruction. A frequently tested concept is what the presentation of an individual with left-sided colorectal cancer is. Therefore, it's important to know that these individuals present with obstruction and altered bowel habits, like narrowing of stool, colicky pains, constipation, abdominal distension, but also hematochezia, nausea, and vomiting. On the other hand, right-sided colon cancers grow as exophytic masses, but they do not tend to cause colon obstruction, because the right-sided colon has a larger diameter than the left. Instead, right-sided tumors tend to cause chronic bleeding, eventually causing iron deficiency anemia. Moreover, keep in mind that colorectal cancer is the most common cause of iron deficiency anemia in postmenopausal women or men aged 50 or older. Other manifestations of right-sided colon cancers include progressive fatigue, malaise, and weight loss. Common complications of colorectal cancer include local and distant metastasis, but also bowel perforation and peritonitis. Non-enterococcal group D streptococci and Streptococcus bovis can also cause bacteremia and subacute endocarditis. Now, as far as screening goes, you should screen average risk individuals at the age of 45, while individuals with a first-degree relative who has colon cancer at the age of 40, or 10 years prior to their relative's diagnosis. Screening includes visualization methods, like colonoscopy and flexible sigmoidoscopy, and laboratory findings, like fecal occult blood test, which is further subdivided into Gaiac fecal occult blood test, or FOBT, and fecal immunochemical test, or short FIT. On the other hand, individuals with hereditary polyposis syndromes or inflammatory bowel disease have different guidelines for screening, like earlier and more frequent colonoscopies. Now, diagnosis of colorectal cancer, just like screening of colorectal cancer, includes visualization methods, like with colonoscopy and flexible sigmoidoscopy, but it also includes imaging methods, like CT colonography and barium enema X-ray, which might show apple core lesions. But don't forget, diagnosis is confirmed with biopsy.